There is mathematical relationship between the drug concentration and the clinical response. And don't worry, I'm not going to talk about mathematics. We just need to be familiar with some basic terms. Agonist means chemical, which binds to a receptor and results in a response. Antagonist is when binding to the receptor is not associated with the response. Allosteric activator binds to the receptor at different site. Allos means other. Allosteric inhibitor also binds at the receptor at a different site. We have three types of the agonists: full agonist, partial agonist, and inverse agonist. Full agonist produces a maximal response. On the chart, x-axis represents drug concentration, and on the y-axis we have the pharmacological response. Full agonist gives us the full effect. For example, morphine is a full agonist of the mu-opioid receptors. Partial agonist is incapable of producing maximal response. It's less effective than a full agonist. For example, buprenorphine is a partial agonist of the mu-opioid receptors. On the chart, it will be like that, less effective than the morphine. Inverse agonist induces response opposite to the agonist. On the diagram, it will give us the opposite curve as agonist. And in contrast to that, antagonist is a chemical that binds to the receptor and gives no effect. On the diagram, it will give us no response. For example, naloxone is antagonist of the mu-opioid receptors. To summarize, full agonist will give us full response. Partial agonist will give partial response. Antagonist has no response, and inverse agonist will give us the opposite response. Antagonists can be competitive and non-competitive. The effect of the competitive antagonists can be reversed by the increased dose of the agonist drug. Non-competitive antagonists can be partially reversed by the increased the agonist dose. They appear to decrease the efficacy of the agonist. We have a physiological antagonists. They work on the different receptors. This is happening when two agonists with the opposite effect are given at the same time. For example, if you give vasoconstrictor, such as phenylephrine, and vasodilator, such as nitroglycerin. Chemical antagonism is formation of the chemical complex between the drug and antagonist. One of the examples are rocuronium. You can see the formula, and its antidote is sugammadex. As you can see, sugammadex has a characteristic chemical shape which binds to the rocuronium and neutralizes it. We use sugammadex to reverse the neuromuscular blockade caused by the rocuronium. Another example is the heparin and its antidote protamine sulfate. Unfractionated heparin is negatively charged. Protamine sulfate is positively charged. Protamine binds to the heparin and neutralizes it. This example of the heparin reversal is very often used in the cardiac surgery. Another term that you need to be familiar with is potentiation. It's increasing the potency of the agonist. Glucocorticoids potentiate effect of the catecholamines. Benzodiazepines potentiate effect of the alcohol, and vice versa. Alcohol potentiates sedative and CNS depressant effect of the benzodiazepines. Also, barbiturates and benzodiazepines and barbiturates and alcohol also potentiate effect of each other. That's why intake of these drugs together is contraindicated. Affinity is the ability of the drug to bind a receptor. Potency shows relative doses of two or more agonists to produce the same magnitude of the therapeutic effect. Efficacy is a measure of how well a drug produces a response, or effectiveness. It's more clinically relevant. Efficacy is the maximal effect that drug gives. Think about full agonist. It gives us 100% effect. Partial agonist gives approximately 50% of the effect, and obviously a full agonist will be more effective than a partial one. Potency is the amount or dose of the drug needed for a given effect. A less amount or less dose of the drug is needed for desirable effect means that the drug is more potent. You need less drug for the maximal effect, and vice versa. More drug is needed for the maximal effect, the drug is less potent. Cumulative dose response represents percentage of the population responding to a specific drug effect vs dose. On the diagram, blue line represents median effective dose, and red line represents toxic dose. ED50 is effective dose in 50% of the population, represented by the blue line. TD50 is the toxic dose for the 50% of the population, represented by the red line. You need the correct dose for the treatment. In a lower than needed dose, the drug will be ineffective. In higher than needed dose, the drug will be poison. As Paracelsus defined, the dose makes poison. It means that in high dose, every drug will be poison. And what about safety? How safe is the drug? Therapeutic index and therapeutic window estimates the safety of the drug. Drug safety is measured by dividing median toxic dose over median effective dose. TD50 is divided over ED50. A difference between ED50 and the TD50 is called therapeutic index. Safe drugs have high therapeutic index value. It means that there is huge space between the ED50 and the TD50. Drugs with low therapeutic index are more dangerous and require monitoring. Drugs with low therapeutic index are theophylline, digoxin, warfarin, lithium, etc. It is very easy to be poisoned by these drugs because there is very little difference between the ED50 and the TD50. We don't use theophylline anymore for the pulmonary disease, but we'll still use digoxin, warfarin, and lithium. And we're measuring the level of the digoxin and the lithium to determine the correct dose. Imagine the patient takes warfarin, it's anticoagulant. If the concentration of the warfarin will be here, it will not produce anticoagulant effect and the patient may develop thrombosis. If the concentration of the warfarin is here, the patient will develop bleeding. That's why it's crucial to maintain the concentration within the therapeutic window, and that's why we are measuring the INR to check how anticoagulanted is the blood in patients who take warfarin.